Yes, so hi everyone, welcome back to our weekly series of FSHD Society Sequester Camp webinars. We created this webinar series especially for our FSHD community. We're going to run this every Thursday at the same time for as long as we need to. We're going to share information, resources, and especially share social support. We're also hopefully streaming this live on Facebook, so you can join us from there if you prefer. But today, on our fourth of these awesome webinars, we have some very special guests with us, and I'm going to turn it over to June Kinoshita, who's going to introduce them.
Thanks, Beth. So our guests today are Hinwa Dumyati, MD, Rabi Tawil, MD, and Jeffrey Statlin, also MD. Dr. Dumyati is the Professor of Medicine and Director of Communicable Disease Surveillance and Prevention at the University of Rochester Medical Center. Her research focuses on tracking and preventing infections of public health importance. So she has previously worked with local health departments during the SARS outbreak and the 2009 H1N1 influenza. And she's presently assisting nursing homes in managing the COVID-19 outbreaks in their facilities. So she is right there at the forefront of what is going on right now with COVID-19. I also want to introduce Drs. Tawil and Statland. They're very well known in our community. They are co-principal investigators of the FSHD Clinical Trial Research Network. Dr. Tawil is Professor of Neurology at the University of Rochester Medical Center and Director of the Field Center for FSHD Research. His research has included an extensive natural history study and several controlled therapeutic trials for FSHD. Dr. Statland is Assistant Professor of Neurology at the University of Kansas Medical Center. His research focuses on developing sensitive, disease-relevant outcome measures for FSHD clinical trials. We will start today's webinar with Dr. Dumyati. There will be time for questions after her talk, and following that, Drs. Tawil and Statland will be speaking about what is going on currently with FSHD research. And there will be time after their presentation for additional questions. So with that, I'll turn over the podium to our first speaker. Welcome, Dr. Dumyati.
Thanks for the introduction. And I'm an infectious disease physician, so I will not be able to answer any question related to neurology. And I have the backup there after me. So all of you, know of the disease called COVID-19. And first of all, when it emerged in China, it emerged probably at the beginning of December, but they started to see pneumonia of unknown etiology mid to late December. And they identified eventually in early January that the virus is a coronavirus. And it's called coronavirus because on electron microscopy, it has spike like a crown. And in January 30th, the disease has spread beyond China. So first it was in Wuhan, China, and it was spread over multiple countries, and it triggered the WHO to declare COVID-19 a public health emergency of international concern. And by March 11, as we saw more countries having outbreak due to this virus, the WHO declared COVID-19 a pandemic. And as of today, there have been 1.5 million affected cases with 89,000 deaths globally. And you could see in the US, the number of cases is around 432,000. And the number of deaths, who are mostly in New York City, is around 4,571. This is a map of from the CDC showing kind of the darker color is where the disease is more prevalent. So you can see New York State, Connecticut, the Southern Florida, Texas, California, and Washington states are kind of hot zones right now. We expect this disease to probably spread over the entire country. And so what can we do to prevent a pandemic? What happened with this virus is we have never seen this virus. So we have zero protection, zero immunity to it. And that's why when we are exposed, we get sick from it and we can transmit it to 2 or 3 more people. So the more people are infected, the more there is, additional infections. So it kind of multiplies very quickly. And then what we're trying to do to prevent the pandemic without having a vaccine is to try to see, how can we prevent people that are infected from infected other people? And one way to do it is to socially isolate. So I can see only my family, I don't see other people. So if I'm infected, I don't infect, 3 people. I could probably infect just 1 person in my household. Not everyone exposed though is clinically infected or infected. And so what we're trying to do is prevent this, as you can see on this, this graph, a very rapid increase in number of cases. Because some of the cases, most of the cases are mild, but some of them are severe. And the more severe the cases are, the higher the number that have to go to the hospital. And you might end up at the point where you don't have really enough staff or enough, enough ventilator to take care of the sick people. So what we're trying to do right now, what is similar to what we did in all the influenza pandemic, is to try to isolate ourselves from other people, stay at home, so less people are infected if any of us are infected. And so this is what's called flattening the curve. I'm not sure if this will result in less number of people infected, but what happened, the people infected are infected, the number are, developing slowly. So there is less, there's more capacity at the hospital to take care of those sick people. And so to understand, how to prevent this and why are we recommending what's called social distancing? And it is because this virus is transmitted from close contact in someone who coughs what's called droplet. And you could see a picture here, what happened if someone coughs or sneezes. And if you're standing in front of that person, you could inhale the virus, those particles, or you can contaminate your eyes. And you become secondarily infected. So this is the reason why we say, stay away 6 feet from another person, because usually that's what happens when people sneeze or cough. The other way it's contaminated, if you, for example, cough or sneeze, and then you put your hands in front of your face, and then you touch a table and someone else touches the table, then that other person can get their hand contaminated, and if they rub their nose, their eyes, their mouth, they can get the infection that way. It's probably a less common way of transmission, but it's there. And that's why we're recommending, if you have someone sick with this disease at the home, to really contaminate or clean all the surfaces that are commonly touched by everyone. There is some recent data that shows that not only the sick people can transmit this disease, there are probably people that are very mildly symptomatic or asymptomatic that can transmit COVID illness. And so how do you prevent transmitting? The first thing we have done in the US is what's called social distancing, trying to stay away from other people. But eventually we had to, because we have no vaccine and no way to prevent the transmission, we had to ask everyone to stay home. And so there is reduction of contact with other people. And more recently, because of the knowledge that people who are asymptomatic can transmit the disease, the CDC came out with a recommendation, and followed by the WHO, to wear masks when you are in common area and you cannot keep your 6 feet difference. The mask, though, would not protect you. The mask is more for people who are asymptomatically infected, so they don't transmit to people that are not infected. And it's important, so even if you have the mask and you go, for example, shopping, you still have to make sure that you don't touch your eyes and you clean your hand as you're going around shopping. Now, the disease has a very wide spectrum. The good news is 80% of the infections are mild, and people recover without having, they can have a cough, a runny nose, or a shortness of breath, but most of the disease is mild, and some people don't even know that they are sick. Most of the people recover. 14% will develop bilateral pneumonia, and some of them, 5%, will be critically ill and have bilateral pneumonia and kidney failure, and they would need to be in the intensive care unit and on mechanical ventilation. And then from the Wuhan experience, the mortality rate was 2.3%. It varies widely depending on the country, and there is we're still trying to understand the reason why some countries has very high mortality rate and some have lower. It's probably a combination how old the population is, and if the availability of ventilator, of intensive care, and so forth. And that's why we're really trying hard to prevent a very big number of people getting infected at the same time. So who gets severe disease? Most of the people, as I said, get mild disease. Some of the risk factor for severe disease is being older, and I guess older is defined 65 years or older. People who are in a nursing home, people with chronic lung disease and severe asthma, people with serious heart condition, people with condition that suppress the immune system, severe obesity, diabetes, chronic kidney disease, and people who are undergoing dialysis and liver disease. It is not clear that pregnant women or children are really at more risk of acquiring the disease or having more severe disease. We know, for example, for influenza, children are commonly infected, and that's how it's transmitted to other people. In this, the children really are very mildly symptomatic or mostly asymptomatic, and the pregnant women, so far, we don't see an increase in more severe disease when they become ill, and there is no in utero transmission. There is a possibility to transmit to a newborn if the mother is ill because of direct contact. Now, the other question that has been a big debate, when the COVID illness started to be seen in the US, we did not have a test in place that could be used widely. So there have been restriction in the US of who should be tested. And it is like flu. If you think about it, many people have flu every year and not everyone gets tested. We test people that are hospitalized. We test people that have underlying medical condition that puts them at a higher risk for severe disease. We test people in a nursing home because we want to prevent outbreaks. So this is the same thing we have to think about when we think of testing for COVID. If you have an illness that sounds like a flu with cough, fever, sore throat, at this time, you probably have COVID. Influenza is no longer prevalent. Months ago, we probably couldn't differentiate between the two, and we were testing for both. And so we're recommending, because we have limited supply of test and swab and lab capacity, to do the test when the test makes a difference clinically. So your physician would decide, I need to test you because this is going to change what I do. Otherwise, we're telling people that are home and not quite ill to just stay home like you would do with the flu. Now, as far as treatment, so far we have no approved treatment for COVID-19. There's a lot of hype about hydroxychloroquine, which is a medication that is used for lupus and rheumatoid arthritis. And in one study in France, they showed that at 6 days, maybe people who got the combination had a lower rate of viruses in their nose, in the nasopharynx. However, that study was recently reviewed and has been retracted. But that has created a lot of hype. There is a lot of people and a lot of physicians, I could say, that have kind of hoarded this medication, which is really not good for the people that need them, like people with lupus. There are some studies ongoing. We don't really have any knowledge if this drug alone or in combination with an antibiotic called azithromycin is at all effective. There is some studies ongoing with an antiviral drug called remdesivir, and it also got a lot of interest because the first patient that was in Washington State was treated after he developed pneumonia, and he promptly recovered. But right now, we don't have any information if it's effective. Caletra is an HIV medication, and one study was recently done, and it showed no benefit. A monoclonal antibody that's called tocilizumab has been used, and again, studies are ongoing, and we don't know if it's effective. And the last thing is kind of the new things is convalescent plasma. Is taking serum from people who are infected and giving it to sick people with pneumonia. Again, we have no data. So right now, most of the care is supportive. In the hospitals, there are many studies ongoing to try to study these medication and see which one is the most effective, if any. The other thing that is starting, there are several vaccines that are being developed, and the first clinical trial has started. The bad news is, even if we have an effective vaccine today, it's going to take at least a year to have something that could be widely used. And that's it. Any questions?
Thank you very, very much. Yes. There are some questions. One is a question asking, do you think the statistics provided by China are credible?
I cannot say. There have been some debate about the statistic in China, but I really have no knowledge regarding that.
Let's see, is a question or comment. I know the premise of flattening the curve is to prevent exceeding the healthcare community capability. I believe the total number of cases would not necessarily be less and due to the curve flattening, but assume that due to keeping within the capabilities of the healthcare system, the expectation would be that there would be many fewer lives lost due to flattening of the curve. Is this a correct?
It's very correct. That's exactly what we're trying to do. Because, you know, the example, if you have, for example, 10 people going to the hospital today and need a ventilator, we have it. If we have 100 people going today to be on the ventilator, we won't be able to support all of them. And we would have to decide who gets the ventilator and who doesn't. And so that's exactly what we're trying to do.
I would imagine too that with less burden on the healthcare providers, that it also reduces their risk because they're at very high risk of contracting COVID.
Yeah, there have been few healthcare workers that have acquired the disease. Most of the acquisition is when the healthcare worker have not, you know, used the right protective equipment because they did not know that the patient might have COVID. More recently, as we see more widespread COVID in the hospital, everyone is taking precaution and assuming any case, any patient in the hospital has it. And that's a very good, you know, a very good comment.
What's the current status of testing? Because we knew it was in very short supply initially, and the information we're getting about the availability of testing seems to be quite variable. So what is your...
It is much better now because now all the labs, not just the state lab, are able to do the test, and it varies by lab and by state and where you are. But the capacity has increased. We still, for example, where we are in Rochester, New York, we're still not able to test everyone who is an outpatient home. We don't have enough swabs. We don't have enough reagent to do the test. But it's definitely improving, and hopefully with time, everyone who has the disease can be tested.
Do you have an estimate or have someone estimated the real rate of spread of the disease, since the vast majority of people who have it will probably never be tested? Are there models that...
Yeah, so what the CDC, they just developed an antibody testing capability, and they're starting to do study where they would go in a region and test everyone to see what proportion of the population has antibody, which means they have been exposed or had maybe subclinical disease. So that's coming, and we'll know in the future, you know, is it 10% of the population? Is it 40%? Right now, we don't know because we don't test.
Mm-hmm. Okay, a question here. Is it safe for a nurse to wear the same mask all day when taking care of both coronavirus and non-coronavirus patients?
We have a limited supply of masks, and that has been a big challenge in this epidemic. We have a limited supply of gowns, masks, eye covers. And so we have to, you know, ask people to keep the same mask on. we're trying to do it so we are putting a shield above the mask so the mask stays non-contaminated. And we're trying to educate the healthcare worker not to touch the front of the mask, which is really what is contaminated. And because of the limited availability of masks, we are keeping the mask on all day long, which is really very hard to do. And many hospitals, are kind of assigning, for example, 1 mask a day that you have to, especially the one that are called respirator, that you have to have, you can wear them over 3 or 4 days, and then they have to be cleaned with hydrogen peroxide so you can wear them again. Ideally, you don't want to reuse anything, but because of the limited supplies, we have to do it.
Do you have an opinion on when antibody testing might be available? And won't this be needed in order for us to get back to a normal life?
I think it would be helpful eventually to get antibody tests and understand what it means, though. And understand if you have the disease, do you have immunity that lasts for months, for years? And right now, we think based on data from other similar viruses like the SARS virus, that people could be immune for a year or 2 after they acquire it. Right now, with this virus, we don't have enough data to know if you have lasting immunity. That's really key to kind of stop the spread of this infection. As once you have enough people that are infected, the outbreak will stop if people are immune. So at this point, really, I don't have an answer. Hopefully, many people would be immune, and then there would be not enough people to get infected. But ideally, if you really wanted to stop this very quickly, you need a vaccine. And that's really the answer, but it's going to take a year. So we have a lot of work to do to try to understand, this virus and, how it's transmitted, how can we control it, and what's the immunity to this virus, and how long does it last?
Thank you. Another question, are asymptomatic infected people the biggest danger because they could be spreading the disease to family members or others without even knowing it?
So this was something that was recently described, and it's probably not the common way that the disease is prescribed. The more probably virus you have, the more symptomatic you are, the more you cough, it's probably more likely that you transmit it. But there is some cases, cluster of people in families where the initial person didn't have any symptom and never developed any symptom, and then multiple family members got the disease. So they have tested, there have been studies that tested, multiple family members that had an exposure, and some of them remain asymptomatic, even though they had virus that was positive when they were tested. So it is something new, and this is why we're recommending the masking in public. And this is a reason really to keep our distance from other people, even though they might appear healthy.
Great, thank you. A question back to masks and also gloves that people might be using at home. Is there a way to clean them between use so that?
So the masking, the CDC is recommending, because there is a shortage of masks for healthcare workers, to really use cloth masks, make your own. And then these need to be laundered. If you go out and you use them, you should probably launder them. The virus doesn't last very long, so if you leave them away for 3 or 4 days somewhere sitting somewhere, the virus cannot replicate. It needs a human being to replicate, so it would be okay to reuse. But if you're able to launder it, you should launder it. And remember, when you take your mask off, don't touch it in the front, touch it on the side. The front is what's contaminated. And this is probably what's happening in healthcare worker. They're all masked and everything, but when they take their mask, they touch the mask, they touch their face, their eyes, and get themselves contaminated. So remove the mask by going behind your ears and taking it out. Wash your hands after you take it off, and then launder it.
Great, thank you. One last question for this section. What are the total deaths that are projected right now in the US? What's the range, I guess, because nobody knows. And then how do those numbers compare to, say, influenza mortality for the last several years?
I'm not sure. There have been multiple estimates about the mortality, and we're really, struggling to understand because it's very high, for example, in Italy and Spain. It's much lower, it's much lower in other countries. So I am not sure. We know that the mortality is probably 10 to 15 times higher than influenza. But I don't know what's the latest estimate. And I'm hoping with less people infected and better care that the mortality would be lower than what they have predicted. But I don't have an estimate myself.
Yeah. Well, thank you so much. Okay, we're going to switch now. Don't go away because I'm sure there'll be other questions afterwards for you, Dr. Dumyati, but we'll switch to Dr. Tawil.
I'm going to follow up with a little bit of an overlap to what you heard from Dr. Dumyati. My title is COVID-19 and you, do's and don'ts. And some of that is repetitious, but it really, I'm trying to focus a little bit more about COVID-19 and FSH in particular. So again, one of the things that is important is that you get reliable information, and there's a lot of information out there that's false and not supported. And so the really good source for information is the CDC. It's reliable and it's always updated with the most recent information that's gathered. And when you go to the website, there are many different titles to and answers to questions that a lot of people have. So it's a good place as a resource for good and reliable information. So who is at risk for most severe disease? And Dr. Dumyati went over that. This is the list from the CDC. And we've gone through that. All of those things are at the same rate in patients with FSH as in the general population, with one exception is that there's a subgroup of patients with FSH who have chronic lung disease. And I'll get to that in a minute. And the other thing that's important also to remember in any muscle disease is that if somebody has significant muscle weakness and they get moderate or severe infection, they're going to have a hard time with recovery. Even somebody who doesn't have underlying muscle disease, being in the hospital for 20 days, sick and with a high fever and septic, you're going to lose a lot of muscle mass and strength. And if you have already underlying muscle disease, that's going to be worse. So, a subpopulation of patients with FSH do have respiratory involvement, and that puts them at a high risk for more severe disease. And roughly, we don't know the exact percentage. Different studies have found different numbers, and it's mostly because the samples are somewhat biased depending on where you look. But roughly about 20% of individuals have some type of respiratory involvement. Some of it can be mild, some of it can be more severe, but only a small fraction of the 20% will have kind of significant respiratory disease. And that's defined as a vital capacity of less than 60% of what's considered normal for the size of that individual. Certainly if some of you are using a BiPAP, CPAP, or a Trilogy machine for ventilation overnight, then that you fall in that category. The other thing that's important is individuals who have weak cough are also more susceptible to get lung infections. So how do I avoid getting infected if I have lung disease? Again, it's the same rules for everybody, but somebody who is at a high risk should be even more cognizant and more aware of what they have to do. And I won't go through that again, but social distancing, work from home, I guess I'll go over it again. Avoid large gatherings, use face masks when outside, and frequent hand washing. And that, you know, we kind of have to keep reminding ourselves that we need to do that, because it's very easy to get distracted and not do some of those things. But it's really important to do that in the long run for everybody. For those with BiPAP, CPAP, or on Trilogy machine, make sure that whoever comes to the house to service your machine is not sick and uses the appropriate face mask and gloves and washes their hands before and after they're finished with their service. So here are common questions. What if I'm sick and I have to go to the ER? One of the things you want to avoid is going to the emergency room, because unless you think that you might have COVID-19, you don't want to go to the ER because it's going to be overrun by a lot of sick people. And so the first thing you do is really seek the advice of your physician as to whether they think you need to go to an emergency room, or maybe this may be better handled either in a clinic or in an urgent care facility, which is less crowded than an emergency room. And if you end up in an emergency room, you want to make sure that the physician who's taking care of you knows that you have a muscular dystrophy called FSHD. They may not know that if you just tell them you have FSH, but if you tell them that you have muscular dystrophy, it triggers a set of way of thinking about how to deal with your condition. And it really works well. I mean, I recently had a patient with another neuromuscular disease in the ICU here with COVID-19, and the physicians in the ICU kept calling me with regards to what are the safe medications that we can use. Can we do general anesthesia with this person because they needed to be intubated and so forth. So having your neuromuscular physician in contact with the ER or the hospital physician is really important. And again, if you have any sense that you have a reduced lung capacity based on your visits to the clinic, you really have to tell your physicians, the physicians who are taking care of you. Again, one of the things that is often raised is if I have a BiPAP machine or a CPAP machine, should I bring it with me to the emergency room? The general response used to be yes, but it really depends on what hospital you're at. One of the issues with the BiPAP machine that has been raised in this particular pandemic is the fact that BiPAP machine is not enclosed like a true ventilator. So there's always a chance of, if you're using the BiPAP and you do have COVID-19, that you aerosolize as you're exhaling some of the air, even as tight as you can make a face mask, there's always some seepage from that, and that can infect people around you, including the healthcare workers. So if somebody needs that in a situation where they're in the hospital or in the ICU, there are special negative pressure rooms that can accommodate the BiPAP if necessary. And again, if you are in that situation, if you are in the ICU, it's really important that the physicians taking care of you make sure they talk to us, to your neuromuscular physician. So what if I had COVID? Remember that the majority of individuals who contract COVID-19 have mild to moderate disease and have a full recovery. And the other thing to remember is that there are no proven treatments for COVID-19 at this point, as was emphasized by Dr. Dumyati. Nevertheless, hospitals provide excellent supportive care, and probably the ICUs in this country are better equipped than in any other country in the world. Despite the fact that there's no proven treatment, medications like hydroxychloroquine, azathioprine, and other antivirals are being used in hospitals. They're not approved by the FDA for use for this condition, but they're used off what we call off-label, and most of the hospitals do offer these medications to patients. There's one thing that you have to keep in mind about hydroxychloroquine is that it can damage muscle. It can cause a toxic myopathy that can worsen the weakness. This is something that's can happen in anybody, whether you have a muscular dystrophy or not. But if you have a muscular dystrophy to start off, it's something that you really want to avoid. It is something that we see from rheumatoid arthritis and lupus patients. We see 2 or 3 cases of hydroxychloroquine muscle damage yearly in our medical center, and probably across the country it's about the same as well. So yeah, I'm going to turn over to talk a little bit about what we're doing in the clinic in this COVID-19 era. And so medical centers have rapidly really pivoted to telemedicine for visits for all of our patients. We still have the same crew at the neuromuscular centers. We have the physical therapist, all of the people that you need, and they can be accessed with telemedicine. Visits are done either by telephone or video using apps such as Zoom to communicate and examine patients. These visits can be set up with a physician or with a nurse practitioner or a physical therapist or a social worker. And I've highlighted the physical therapy here because there's one question that came in yesterday about, if you're homebound because of you need to remain isolated and you need physical therapy. Obviously, you can't go to a physical therapy center to get your normal physical therapy, but you can certainly get advice about what you can do at home from the physical therapist in the neuromuscular disease centers. And in most of the neuromuscular centers, the physical therapists are ready to talk to you on telemedicine and give you advice about what you need to do. And again, for individuals are stable, these visits work well, but they certainly have limitations. I mean, one of the things we can't do on Zoom is to really do a good exam of you to kind of figure out where you're at with your FSH muscular dystrophy. Are there visible signs of worsening since your last visit? And so if there are really concerns on the part of any of you that you really need to be seen, the clinics are still open for in-person visits when appropriate. And talk to your neurologist if you feel that you need to be seen and you in clinic because of new concerning symptoms that you have, or you just want an in-person follow-up. We can still do that. All of the centers still offer that. And one of the things that crosses everybody's mind is, well, I really don't want to step in the hospital at this very time. But actually, the hospitals are now almost empty of people. So the chance of you getting infected within the hospital setting in the outpatient setting is really minimal. And the clinics and the hospitals have taken many steps to minimize possible exposure during a visit. Everyone is screened before they come in. Visitors are strictly restricted. Most non-essential hospital staff are working from home. Reception areas in clinics are reconfigured to minimize contact between patients. and all staff will be using appropriate protective equipment. So if that, if you really have a concern and you want to be seen, I think you can rest assured that you'll come into the hospital and it's going to be a clean environment that's not going to significantly increase your risk of exposure. And I think that's the last slide I have, but this is a question that came to us regarding pregnancy, and Dr. Dumyati addressed that. And, these are specific questions that came up to us yesterday. Is a pregnant woman more susceptible to contracting the virus? The question is, we don't really know that because you need to do that on a kind of population-based study. As far as the few studies that were done so far, the risk of a bad outcome doesn't seem to be increased in individuals who are pregnant. But again, the study that was done in, this was from a study done in, thank you, Dr. Statland, for pointing out that reference, a study done in China of 38 pregnant women who were in the hospital. None of them, all of them survived. And none of them transmitted the virus to their newborn. But again, as Dr. Dumyati pointed out, if you're still sick after you give birth, then you can still transmit it to your newborn at that point. Anything else, Jeff, that you want to add?
No, I think you covered it. Maybe we can hear whether there's some questions.
Let's see, there are still some questions about the COVID-19 specifically. Someone wants to know, how long will the virus stay on your clothes if you're out in public and then return home? Maybe that's a question for Dr. Dumyati.
I think that the close contamination in public is not a common way of getting COVID. I wouldn't worry about it. I would just make sure when you get home to wash your hands. We haven't really recommended for in the general community, if you're like going to the supermarket, to come home and change and take a shower. It's different in healthcare worker setting where we are in close with truly COVID infected patients. But in a regular household, in a regular, common, going to common places, we don't really recommend anything to be done with your clothes. Same thing for packages or delivery of food. I don't think that's a risk. I wouldn't worry about it.
Okay. Here's a question from someone who says, I'm currently going to physical therapy 3 times per week. The facility is not large. There are 2 PTs and 2 patients at a time. Everyone is screened before entering and the equipment is constantly sanitized. Should I be concerned about continuing to visit my therapist?
Do you guys want to take this one or do you want me to comment?
That's an infectious disease question.
Many places we really have recommended, to avoid as much as can visit, like especially physical therapy and so forth, because you might have contact with other patients there or the physical therapist. But I know that some of you really need it and you have no other options. So you have to make sure that you have your mask on, the person taking care of you has a mask on, and they're washing their hand, they have gloves, you wash your hands like you would do anywhere else. But, I don't know from your side, Rabia, any other recommendations for people who need physical therapy?
No, I mean, I would, I'd like to hear what Jeff has to say. I mean, I think in a situation like that, certain people, it's really important to keep going with the physical therapy in an environment where they've, narrowed everything down and separated patients and have only, a couple of patients at a time. And if they're taking good precautions, I think that should be okay.
Yeah, I mean, I think that, being physically active, this is important not just for, someone with FSHD, but also for your mental health. I think wherever possible, if they can give you a regimen that you could do at home, you can ask them for that, and that would, help prevent your having to be there and interacting. But if you are going and that's necessary, again, it may depend a little bit on where you live and how common it is in your particular location. Make sure you wear a mask and try to just maintain that 6 foot distance between people while you're doing the physical therapy.
Great, thank you. So maybe we can move on to Dr. Statland now, if you can.
If I can figure it out.
Figure out how to share your slides.
Yeah.
See, this is just like an in-person seminar, right? Where there's a big shuffle and confusion between. That was really smooth. Very good.
All right. And so I want to sort of talk a little bit about something a little different now. So talk about how COVID-19 is affecting our is affecting our research projects. And just like the pandemic has really affected our day-to-day life and everything that we're doing, the pandemic has also really had an effect on our research projects. And so what I'd say is, research doesn't stop just because of the COVID-19 pandemic. We as researchers, we're really committed to continuing what we feel is our FSHD research mission, which is filling in the gaps in our understanding of the clinical course of FSHD, improving our systems for care and care delivery, developing the tools and the infrastructure to help support clinical trials and therapeutic development. I think many of you can see the picture I have here and the band plays on. That's actually from a Beatles album. And some of you may know that they actually put that out after the band had already broken up. And so this is one of these cliches that you hear in the community that really can be interpreted multiple different ways. And one way might be that we're sort of oblivious in the setting of a crisis and just going on with what we're doing. But I think the other way to think about it is it's really a testament to our, our perseverance and our spirit to continue working even in the face of adversity. And that's how I think about it here in terms of research. And this is the other cliche that we often hear, which is that every cloud has a silver lining. And indeed, whenever we're faced with something, that's made our lives difficult or a challenge that we didn't see, there's usually opportunity built into that. And I'll return to this in just a couple minutes. When we think about the kind of adaptations that we're having to make in the setting of COVID-19, you do have to understand that our research institutes actually sort of distinguish our studies and throw them into two loose classes. One we call observational studies, the other we call interventional studies. Observational studies, these are ones where we're really just following people and we're seeing what happens to them over time. We can be looking at things like blood or tissue. We can be using imaging devices like an MRI, measuring your strength or function, or we could be using questionnaires like the cartoon you see illustrated here. But the truth is, for many of our institutions, we're no longer performing in-person visits. This is really a risk versus benefit calculation for us, and we feel like the risk of having you come in for those visits is too high right now. That said though, for most of our studies, your continued participation, especially after the pandemic, it's really going to be vitally important for us to be able to meet the aims for those studies. Interventional studies, these are ones where we're doing something. So we're assigning people to an investigational drug or a type of treatment like exercise or a diet. The risk to benefit's a little different here. And so there may be reasons why we really do need to have these visits go on, even in the setting of a pandemic. And many institutions are still doing them, including my institution at the University of Kansas. But you may find that they've been adapted for the crisis. And so you're really going to need to check with the institution if you're in part of one of these studies or your local research coordinator. But I'll return to this in a moment. When we think about observational studies, some of you may know that Robbie and myself, we're running what's really one of the largest observational studies that's ever been done in FSHD. This is a study of 220 individuals who we're seeing at 8 sites across the US and 3 sites in Europe. Our purpose for this study was to help us get ready for clinical trials, to get information that these drug companies needed to plan their clinical trials. And thanks to a lot of you who may be watching this, we really enrolled quickly. So it was really fantastic. We reached our goal of 200 individuals in a short time period. But because of this, we're actually getting heavily impacted by the pandemic. All of our US sites and all of our European sites are currently closed for research visits. Some of you may not know what sort of goes into creating a study like this. I mean, to get this study up and running, it took 7 years of Robbie and I working together. It's taken multiple millions of dollars really to get this up and running. So the study, it's really important. And the outcome of the study is very important because we still have many companies who are planning drugs and therapeutics for FSHD and really need this data to help them plan for those future clinical trials. So it's not like we're just going to close shop and say, oh, there's a pandemic, you know, now we can't do it. It's really about how do we adapt. And so when we think about adaptation, many of the things that we're doing in our clinical trial for Resolve are the same kinds of things that other observational studies are doing. Each one may be slightly different. So again, I'm going to urge you, if you're involved in a study, to check with your research coordinator or the institution. But there's some simple things you can imagine we can do. If part of what you're doing is filling out questionnaires or forms, anything that we could have you do equally well as home, well, we're going to do it. So we'll be mailing forms to people so they can fill them out at home. One question that sort of comes up when people are filling out these questionnaires is sort of, well, but how are we supposed to answer the questions? Because there's a pandemic going on and things have changed so dramatically. In general, the right answer to the question is the one that applies to you right now. The pandemic, unfortunately for all of us, has become part of our natural histories and what we're having to deal with. So the right answer is the answer that's right for you at the time you're filling it in, unless the question specifies otherwise and asks you to think back over a month or a year. Some other simple things that we can do, well, we can just expand those visit windows. So instead of seeing someone at 12 months, we may say, well, we'll open this up so we could see them at 15 months instead. And this is a simple thing that we can do. Of course, the longer the pandemic goes on, the harder it may be for us to accommodate these research visits, and people may be missing them. So another thing that we may do, and we're also thinking of doing this, would be to add an additional visit a little farther out in time so we have a stable time point where we could see everyone in person to end the study. And the last piece of this is, well, we can think about doing remote assessments. And I want to just take a moment and talk a little bit about remote assessments, because I think this is a concept you may have heard of, but I think we've been very interested in this. And, you know, as we think about preparing for clinical trials and doing research, remote assessment just means we're going to get information that can be gathered while you're self-isolating. So really while you're at home, or if the pandemic ends, just doing whatever you would normally do in your daily activities. We feel like this is really a more natural environment, and it's really creates less burden on the participant if we can do it. The types of things that we can collect really run the gamut from questionnaires to things we may get directly via a two-way video interview, are using technology like mobile devices, or the picture you see here, which are wireless motion monitors. This is a company called APDM. They tell you things about how your body moves in space. We actually piloted this in FSHD, and some of you may have participated in that study. I think some of the techniques and approaches we're really serious about, and we're planning to actually start in our studies probably in the next few months to a year. The first one is what I'm calling monitored assessments. This is really an approach where it's meant to mimic what we would do in person, but do it with you at home, so you don't have to come in. It would require a two-way video to do it, and it would require an evaluator talking you through and teaching you how to do an activity. They're usually very standard activities, how you move your shoulder, how you maybe get up from a chair. The advantage of doing it this way is it really matches what a drug company likes to measure in our in-person visits. So it's going to fit with their model of how we do clinical trials. Some of the barriers to this is we got to start doing it. And so this has been a real priority for us to try to get this up and running as a model. Other things that we're interested in and we're thinking of doing, hopefully in the near future, would be using mobile devices like your phone or other things like those portable motion sensors. And so we can get these as measurements from your home. Some of the advantages of it is that you don't need us at all to collect it. You just need the device. We can do it at more frequent intervals, but the challenge, of course, for these things are that they're expensive. So they require some additional funds than what we would have for development. We can also get other things like biomarkers or biological fluids that we would use as a type of outcome in a clinical trial. Things like saliva, I think you can imagine how we would get that. We would send you a tube, you could spit in it, seal it up, and mail it back to us. Things like urine or blood, however, this may take a little more work, and maybe it would require us sending someone from a home health service to your house to help collect this, but these are all possible to do. When we think about interventional studies, the risk and the benefit to it is it's a slightly different calculus because you're actually getting an intervention. I encourage you to, if you're in an interventional study, and the large one going on right now in FSHD is with Fulcrum, to check with your local research coordinator. The goal here is really to minimize your exposure while maintaining the data integrity and the safety in the study. Our institutions and our sponsors are working together, and they are meeting literally every day to weigh the risk and benefit versus having these kinds of in-person encounters and letting them continue. If an assessment during a visit could be done from your home and wouldn't require you to come in, we are typically making these remote, or we're allowing you to do them from home. If it requires an in-person visit, either for safety or because what we're collecting that day is the primary readout for that study, what's going to tell us whether that drug is working or not, we're really going to try to minimize the time that you're spending at our centers. Whatever these studies are doing to adapt, you need to remember that your participation, it really means a lot for the success of these studies. And just like Robbie talked about safety, if you come in for an in-person clinic visit, the same thing applies if you're having to come in for an in-person research visit right now. The research facilities are very different from the last time you've been in here. Everyone who goes into the centers is screened for whether they've had either an illness or they've been associated with someone who's been ill or they've traveled. This includes us as well as you who might be coming in. Everybody's temperature will be checked when they enter the building. The staff will be wearing masks and gloves when they see you. And we're going to probably ask you to either come alone or only have one person with you to help you. This is really to minimize the number of people who are in the building and allow us to maintain that important social distancing even while you're at that research visit. So what are we as researchers doing besides wearing masks? As an FSHD researcher and a PI for a research network, Robbie and I, we're adapting our active studies. We're figuring out how are we going to get that important information and make it happen even though there's a pandemic going on. We're still planning for future studies. We have studies that we'll be putting out grants for like we normally do. Some of these may be actual drug studies we're planning to do in FSHD in the future. Some will be to fill gaps in our understanding of FSHD, and it may be that we'll be doing studies to understand the effect of COVID-19 on people who have FSHD. We're still advocating with industry and these drug companies to make sure they're continuing with their drug development programs. And then we're offering some new services through our network to help train sites who are interested in doing FSHD research. As an FSHD clinician, we're committed to providing a high level of care, and we're developing these new models like Robbie talked about in order to get that care delivery to make that happen during COVID-19. And I just want to end with this notion of the silver lining, because there's some things that are happening now that it seemed like it would have taken years, or it has taken years for us to get them to happen, but there actually have happened quite quickly during the pandemic. One of them is these telemedicine clinic visits. Robbie and myself and many of our colleagues, we have been trying to get these set up for years and years, and there's been many institutional barriers to doing these video visits. But it turns out the pandemic was the impetus we needed to be able to offer them now, and we're doing it at most of our clinics across the country. And the same goes for these remote visits for clinical trials. We've spent years now developing some of these technologies. We've been piloting some of these approaches in some of our other diseases as well as FSHD, but the crisis has really become a motivation for us to accelerate these innovations. And I want to end on that positive note and take any questions.
That's really great, especially what you're saying about telemedicine, because we know so many people with FSHD find it extremely difficult to access good care. They're too remote, they're not near a center, and you know, the technology has been there, but there've been these kind of administrative and bureaucratic hurdles. And so that's an excellent point. I'm really excited to hear that. And I hope it continues after this crisis is over, that, you know, just shift the whole paradigm of how we deliver care. There are additional questions, not surprisingly. One is actually probably for Dr. Dumyati is, it seems like the risk demographic that's cited for COVID-19 is basically the same as the one that we see for flu. Is that?
That's true, except the neonate, like the infant, are also at high risk for flu and flu hospitalization. And it's not the case for this virus.
Okay.
So everything else is the same. You're right.
Okay. Let's see. And a question. People are wondering if they use Clorox to disinfect. Is that going to be bad for your lungs if you're breathing in chlorine fumes, I guess? Is that maybe?
I think that's as a question for
either.
Yeah, what I'd say, please don't use Clorox in a closed environment. I understand the fear of wanting to disinfect things. I mean, I think it's okay to use the wipes people are using to wipe things down. I think your standard laundry detergent is thought to be perfectly effective for cleaning your clothing. I don't think you need to go anywhere beyond that. And so I do understand the feeling like you want to just douse everything in bleach, but I would say, yeah, in a closed environment, you probably don't want to be pouring a lot of bleach and breathing that in.
Right.
Viruses are very easy to kill. So, you know, you don't have to use bleach. There might be other things on the market. Just look at the label and make sure it is, you know, COVID or influenza, approved for influenza or killing viruses. That should be okay.
Great. I understand that heat will kill viruses. Is that?
Probably, not the sun.
But for example, laundering something in hot water might be enough. You don't have to add extra strength.
You don't have to. Viruses are very easy to kill, and really they cannot survive alone. They need a human being, human cell to multiply, different from bacteria or, you know, something like Clostridium difficile. They're really easy to kill. And if you leave something for several days, the virus is no longer there. So it's not as easy it's not that hard to kill. And I think the transmission is more, we should care probably more about being close to other people, even if they don't look sick. So that's really kind of the important message. The environmental contamination is important, but I think close to other people is probably what is most common reason why this disease is transmitted.
Great, thank you. A question from someone wondering if researchers are getting themselves tested. Is that, I guess if they're seeing volunteers, are they getting tested just to make sure they're not possible source of transmission? Or
I can answer that question. A lot of hospitals have implemented a screening of all their healthcare workers on a daily basis for fever or respiratory illness, so they are not working while ill. So that's a process that I think is implemented in many facilities. Anyone has to come in, has to make sure that they fill a questionnaire or they take their temperature to make sure they're not ill when they're seeing patients.
Okay. You have a question because we've been hearing a lot about the possibility that patients will have to be triaged if a healthcare facility is overwhelmed, and they're concerned about where would FSHD patients fall in the sort of triage hierarchy. If I don't know, that's a if that's an answerable question.
That's a tough question. Rabia, do you want to take that one?
Yeah, I mean, it's a tough question to answer. It depends where you are and, you know, what the circumstances are. You know, I mean, if you look at life expectancy in FSHD, it's the same as the general population. But I mean, this is exactly the reason why we want to flatten the curve, so we don't get in a situation where we have to make those decisions. And everybody has to think about it this way, because we don't want to be in a situation like what happened in Italy, where they had to make these really tough decisions.
Mm-hmm. Right. So great. We have a question, I don't know if you're able to answer this, about someone who's participating in the Fulcrum trial. If a scheduled visit is pushed out by 4 to 8 weeks, what's the implication for the data? Will that compromise the data for the clinical trial?
See, I mean, I'll start. Jeff can chime in. I mean, the Fulcrum is also adjusting to the change, and this all of the individuals who are participating in the study will get information about how they're going to handle that.
Okay. We have this is a question again about just reducing exposure. So many people are worried about what happens when you bring in food from restaurants into your home. What precautions should we take?
Your contact with a patient, with a person that gives you the food.
Yeah.
I don't think you should worry. I would just make sure that when you get home or when you pick up something, you have contact with other people. If you have hand gel, you know, wash your hands. And when you get home, wash your hands before you do anything. But there is nothing else you need to do.
Okay, thank you. Let's see, we have people asking, well, if telemedicine has become, you know, generally available, is this a time when perhaps FSHD patients who've not had an opportunity to consult a specialist might be able to do so? For example, in your own practice, Dr. Statlin or Dr. Tawil, would you be?
I think that's a fantastic idea. Yeah, I'm still seeing new patients. I'm open to seeing them via telemedicine. We're still seeing, of course, people in person as well in clinic if they need to. I think to see a doctor by, say, telemedicine or video, or whether you need to be in person, really depends on what your concerns are. If you're fairly stable and there's not some acute change in how you're doing, it's perfectly fine to do this by a video visit. I have some things to say if you're planning for that video visit and it'll be the first time you're seeing a doctor. Think a little bit about a few things like where in the house you're going to do it. Get the technology, if it's Zoom or whatever they're using, and download it the day before. Maybe get a friend or a relative to communicate with you so you can see how it works. And you want to be in a position where the doctor can actually see you, your arms and your shoulders, so they can make whatever assessments they need to make via a video if they can.
Okay. Okay. And would the same issues apply that would in a case of an in-person visit, where like if it's somebody who's out of network, would they need a referral from their doctor to have a telemedicine consult, I guess?
No, I mean, we see, just 2 days ago, I had a new patient on my schedule that I saw by telemedicine. And again, we have to kind of you know, if it depends what needs to be done. Again, as Jeff was mentioning, this is somebody who had enough information and didn't need a detailed physical exam that we can put everything together and arrive at a diagnosis or a plan to what we need to do. But yes, I mean, we can see new patients as well as our established patients by telemedicine.
Okay, great. Let's see, there's a couple more questions relating to telemedicine. One is a comment from an audience member who says, I work in pharma collecting data for clinical trials, and we're doing everything to accelerate remote monitoring and telemedicine for our trials. It's great to hear the PI's perspective is aligned with pharma's. Together, we can do this better for FSHD patients. So that's a comment. Here's one from a patient wondering if with telemedicine, would it be possible to expand the qualification criteria for studies to people who are non-ambulatory and I guess otherwise have not been able to go into clinical trial sites?
Well, I mean, I could say one thing about this. It'll depend a little bit on what the study is. For the studies that we do to help prepare for studies, either to help us answer questions about things we don't understand about FSHD, to build new tools for FSHD, or to improve our care and care delivery. Robbie and I have a protocol we've put together that we're actually trying to start it right in the middle of this pandemic. And we're really opening up these criteria for just the reason the person said, that we have several people, you know, who contact us on a regular basis saying they feel left out of the studies. And so we're trying to capture all these different people in our new study, and we're hoping that it'll be up and running sometime in the next few months. But when it comes to a drug study, there's some different issues at play, especially for investigational drugs. So, because sometimes very early in development, there's a lot of restrictions on the type of population they're giving that drug to, and in which case it may or may not be possible for these people to enter the studies. Robbie, do you want to?
Yeah, I just want to emphasize that that even if somebody does not qualify for the study, it doesn't mean that if that clinical trial shows efficacy, that they're not going to be, they're not going to have access to this medication. The reason we choose patients who are not, you know, affected but not severely affected, so not the severely affected or not the mildly affected, is you want to establish whether a drug is working in a fairly quick period of time, and you take the patients who are more likely to show in a shorter period of time a response to medication. So that really the objective is to get something done quickly, demonstrate that it's effective, and kind of take it for FDA approval.
Okay, great, thank you. I think one, questions keep coming in. Let's see, these are probably for Dr. Dumyati. Someone's concerned about groceries. Do you need to wash everything down before you bring them into the house?
I don't do it. You know, there is also that, you know, maybe minute chance that someone who had COVID, you know, contaminated your container and you grabbed it. You know, you could go crazy and maybe when you get home, empty everything from their original container, wash the outside of your, you know, cans and so forth, and then, or put everything in the garage for 3 days. You know, I don't know how common it is to get, you know, the groceries contaminated and for you to get sick. I don't think the CDC addressed that question. I see it in the news. I think it's probably going too much, you know. I think the more important thing when you go and pick up your grocery is the contact with other people, and maybe contact with surfaces that are, you know, the freezer door, you know, the cashier, you know, when you check out and so forth, these are probably more commonly contaminated surfaces. So that's why kind of you have to, as you're going around, keep a hand gel with you and keep washing your hands. When you get out, wash your hands. When you go home, wash your hands, and maybe wash your hands after you empty everything at home, and then clean the surface where you emptied, you put your bags and everything. But I wouldn't go crazy. I'm not doing it.
Okay, great, thank you. Maybe one last question. Will we be able to go back to pre-COVID-19 living without a vaccine? How can we start?
Very good question, and I'm not sure we have the answer. I don't know. I don't know the answers. We were waiting to see, you know, kind of what happens in countries that had it before us when they start, you know, kind of letting people go out, like in China, if there is other waves. For example, from the pandemics of influenza that happened, you know, 1918 and so forth, there's usually a big wave, another wave after everyone went to work. And I'm not sure if what's going to happen this time. I hope it doesn't. And I hope we have a vaccine before then, but there's always a possibility that because not everyone has been exposed and is immune, there's not enough people immune, that once you, you know, we stop the social distancing and everyone goes back to mingle, that we might see another spike. And so we're watching carefully what's happening in China so we can at least have an idea what might happen.
Great, thank you so much. So I wanted to share a comment from an audience member just saying thank you. This is one of the best webinars they've seen. So we want to thank you very much. And now I'll turn it over to Beth Johnston, who has some closing comments.
Yes, actually, I just want to thank everyone for attending our 4th Sequester Camp webinar. And a very, very special thank you to our amazing guest speakers today. Thank you, thank you, thank you. I'm clapping virtually. We'll be updating our Sequester Camp webpage with these recordings. So this is being recorded today, and it will be on our Sequester Camp webinar page. And also we'll be updating that page with other information as it arises. So check back there often. I'm going to post the link to that page in the chat so you have it. And also know that on Wednesday nights at 9, our famous Tim Hollenbach will be streaming the FSHD Society radio show every Wednesday night now. And you can also call in and chat with him live on Facebook as well. And I'll post his phone number in the chat. Also on Wednesday afternoons, Belinda Miller at 2 o'clock is still broadcasting her weekly book reading for her children's book. And you can get details for both of those events on our Sequester Camp webpage. Keep an eye out for the topic of next week's and subsequent week's webinars. And we hope to see you again next week. So take care, everyone. And please, please, please stay healthy and wash your hands. Just like Dr. Dumyati said, wash your hands. Thank you, everyone.
Stay home. Stay home.
Stay home.
Thank you.
Take care, everybody.
Bye-bye.